This short video is a primer on pain assessment in residential aged care. The information here is designed for nurses who are new to working in aged care, but it also can be used as a refresher for nurses who've been working in aged care settings for a while. Though the information here is not targeted for personal care workers or other staff, some of this video will still be valuable for them. Pain affects many residents living in residential aged care. Pain not only has an impact on the body, it can impact all aspects of a person's life, from their ability to function, their independence, their ability to eat and sleep, their emotional and psychological state, as well as interactions with family, friends, other residents and staff. Assessing pain comprehensively and using a systematic approach is essential so that pain management is appropriate, timely and person-centred. Proper pain assessment is important so that we can clarify as much as possible what is causing a resident's pain and ensure that it's managed as effectively as possible. Good pain management should ensure a resident's comfort and promote their quality of life. Ideally, a good assessment should allow for more targeted pain treatment strategies and better monitoring of the effectiveness of a pain treatment. It is especially vital when the resident may not be able to express the pain they are feeling due to cognitive difficulties such as advanced dementia. There are two main types of pain: acute pain and chronic pain. Acute pain usually occurs suddenly and is often related to a specific injury, disease or event. A fractured bone, an ankle sprain, pain after surgery and soft tissue injury from a fall are all examples of acute pain for residents in aged care. This type of pain is usually short-lived and settles once the injury has healed. Chronic pain, however, is pain that has persisted for more than 3 months, beyond the normal healing time, and often has significant impact on a person's psychological state and their social interactions. Examples of chronic pain in aged care include lower back pain, chronic wound pain, some cancer pain, and fibromyalgia. The most likely times that pain is experienced is during personal care with movement or with prolonged immobility. So personal care workers are best placed to notice when a resident may be in pain. They are our eyes and ears. Training PCAs in recognising the signs of both what may be triggering the resident's pain, as well as observing how the residents behave when they might be in pain. Examples could include facial grimacing, guarded movement, expelling air through tightened lips. Ask your PCs if they've noticed anything out of the ordinary about the residents they are caring for, especially when they are providing personal care or getting them to move. And respond when a PCA notices signs of pain by conducting a pain assessment. Most importantly, if you think you see pain, take action. There are a number of pain assessment tools that we use in aged care. The main difference between the tools is whether you ask the resident if they have pain, which is called self-report, or whether you are monitoring for behaviours that suggest pain, which are called observational scales. They are often used when the resident can't talk about their pain reliably, such as when they have dementia in the advanced phases. The most common tools in Australia are the numeric rating scale and the verbal descriptor scale. These scales are great for frequent or daily use when you want to regularly evaluate a person's pain intensity and monitor how they are responding to your treatments. To use the numeric rating scale, we ask the resident to rate their pain as a number from 0, which is no pain, to 10, which is the worst imaginable pain. There is also the verbal descriptor scale, where the person answers in their own words if they have no pain, mild pain, moderate pain, severe pain, very severe pain, or the worst possible pain. Both these scales are very simple to use, and which one you choose should be based on what works at your facility and what your residents prefer. You should know that older people and those with limited education or English often prefer a verbal descriptive scale. We also know that chronic pain often affects how we feel and interacts with others. When helping a person to manage their pain, it is important to keep in mind we are trying to help the person in pain, not only the pathology or diagnosis. So don't just focus on the pain itself or the person's report of pain, but also its impact on that person. That means looking at how they are moving and the level of agitation, for example. So we also need to assess the person's whole experience of pain. What impact is pain having on the person's daily activities, their independence, their mood, their sleep, their ability to interact with others, and so on. For a more comprehensive pain assessment, it is recommended that you use the Modified Residence Verbal Brief Pain Inventory Scale. This scale is best for initial assessment as part of a more comprehensive assessment and a more formal and longer review. The Modified Residence Verbal Brief Pain Inventory Scale asks about recent pain, current pain, and pain during movement, as well as the impact of pain on walking, general daily activities, and interacting with others. When the resident has dementia, still try these scales first: the Numeric Rating Scale, the Verbal Descriptor Scale, the Modified Residence Verbal Brief Pain Intensity Scale. A person living with dementia may be able to answer these scales, so it's worth trying them if they seem interested, but try to choose a suitable time to use these scales. Avoid asking during busy times or if there are many distracting noises. Adequate lighting in the room may help too. Try not to rush the resident. Speak slowly and clearly using effective body language to aid understanding. And try to speak in the moment. So ask about pain now, not about pain in the past, which relies more on memory. As dementia becomes more advanced, you may need to rely more on observational pain scales. When a person has advanced dementia or problems with cognition or communication, you should rely more on observing how the person behaves. It's important to observe a person while they are moving, while they walk, when they are being transferred or moved, and during personal care, and during other activities, and when they may have been immobile for a long period of time. Movement often triggers pain. It's also important to observe them after they have been given an analgesic. What, if anything, changes? There are 3 main observational pain scales: the ABBY, the painACT, and the painCheck. painCheck automates some of the observation by using a tablet, iPad, or smartphone. All the scales focus on behaviours that may indicate a person is in pain. Their facial expressions, their verbalizations, like what they say, as well as their vocalizations, like the sounds that they make. You should also observe their body movements, their interactions with other people, changes in their routines, and any indications of their psychological or mental state, like irritability. It is not part of this training course, but there are some resources available online and videos on how to conduct observational pain scales. Both you and your care staff should be trained in what to look for in these signs of pain. You can find all these scales online, such as at the Australian Pain Society's website. Where possible, a multidisciplinary approach is crucial for effective pain management. As the term suggests, a multidisciplinary approach involves collaboration between available staff who may include nurses, physicians, physical therapists, pharmacists, occupational therapists, psychologists, and other health professionals to address pain as comprehensively as possible. Not all on this need to be present, but those who are should work in a coordinated and collaborative way, communicating clearly with each other on what they are doing. As much as possible, the resident in pain should also be included in the planning and implementation of the pain management plan. Consider the following elements when conducting a comprehensive pain assessment. 1. Gather a comprehensive pain history, including onset, location, duration, and aggravating or relieving factors. Also consider general medical history associated symptoms and recent falls or injuries, weight loss, etc. 2. A physical examination and other investigations such as blood tests and imaging. 3. The physical impact of pain on any movement, including level of comfort in personal care and daily activities. 4. Current treatments being used and their effectiveness, previous treatment tried in care, and how they have managed their pain in the past, noting any adverse events that might influence their choice in future treatments. 5. Consider the assessment findings in discussion with the resident and the multidisciplinary team, whilst bearing in mind the overall care priorities and balancing likely benefits of any treatments versus any potential harms. 6. Document the assessment findings accurately. So pain assessment is a critical and ongoing component of good pain management. Using standardised tools and comprehensive approaches that address as many of the residents' pain experience as possible are recommended. These should include regular comprehensive assessment to monitor progress and multidisciplinary teams so that pain assessment and pain management are as person-centred as possible.